Hey everybody, I am going to flip over to the PowerPoint and get to where we left off, and we will move forward with pharmacology. I hope you guys did well on your quiz for the first two portions, and we're going to talk about routes of administration. I think we stopped on principles. Yeah, we finished. Actually, we stopped here on principles of pharmacodynamics. So I do want to talk to you guys. One more thing I don't guess I mentioned earlier is that starting today, as you saw, you had a practice question and a math question. So we can start having regular bell ringers like that. This week you will get some practice questions or a kind of a review that will be a study guide for your semester exam. That way you have it a couple of weeks. I'm going to give you about 100 questions to practice. I'll give you a certain amount of time to work on those, and then I will make sure that you have access to the answers and to the reasoning behind the answers. So just be sure that, maybe we stopped back just a little bit. Medication interactions. Actually, I think we stopped. I'm sorry. I thought we were further along than we were. We did therapeutic desired effect. I think we stopped it. If we covered adverse medication effects, we're going to cover it again, just because it's so important. So so you'll be doing practice questions, a medical math question, maybe a couple of practice questions every day, pretty much from here on out the rest of the year. These are all retired medical assistant test questions. We'll try to stick fairly well. Some of them will be related to what we're doing. Some of them will go back to what we've done before. But your semester exam will basically cover those chapters, those reading chapters I've given you so far, which is pretty much, as we finish pharmacology, everything that we've done this semester. We will just have practice questions related to that to help you guys see what test questions will be like. The more test questions you see, the more likely you are to do well on that exam. And so I'm going to give you about 150 practice questions to prepare you for your exam, and I will probably choose somewhere between 75 to 100 of those questions for your actual exam. So just kind of putting that out there that will start today, wanting to get you guys geared up. Okay, now let's get back to adverse reactions in pharmacology. Adverse medication reactions, those are things that happen that we didn't necessarily plan on happening, or that was not a positive outcome for a patient. That's a clinical change that we didn't want to happen. It can cause harm or discomfort to a patient. So we have to consider that. We have to think about that in relation to a patient's condition too. And I think we did talk about this. Like if a patient has asthma, we don't want to give them a medication that can cause shortness of breath or that can increase histamine release, because those are things that are naturally happening to people with asthma, which could onset a severe asthma attack. So we just want to be sure that we are being mindful of that. Also, patients sometimes, due to their condition, so if I have a patient that is an end-stage, back to asthma, COPD, if we have a patient who's an end-stage COPD, which is a chronic obstructive pulmonary disease, if they have a chronic obstructive pulmonary disease like emphysema, asthma, a type of asbestos poisoning to their lungs, mesothelioma, lung cancer, we want to be sure that what they're taking is not going to affect them even in the smallest way, because if someone is at an end stage or even at a moderate stage in a disease, a stage 3 or 4 if it's a kidney disease, just a little bit of effect can cause them a lot of issue in the end. So we have to be very mindful of what's going on with our patient and be looking for those adverse reactions, making sure we're following up and making that it's not causing an issue. So we just want to be sure that we're mindful of those things. Severity, sometimes with an adverse reaction, sometimes it's hives on the skin. Sometimes it's GI upset. Sometimes it's just that it makes the patient too drowsy, or it makes them not able to focus and concentrate. Those may be kind of minor, all the way up to shortness of breath, tightness in the throat, inability to breathe. So it can range anywhere from there. Sometimes we want those adverse reactions from medication. Sometimes we give patients a medication because it has an adverse effect. So sometimes we give patients a medication, like we give patients sometimes, and we don't give this a lot anymore, but sometimes we do. We give something called Demerol and Phenergan together. The Demerol is for the pain, but it induces nausea. So if it induces nausea, we've got to give them something for the nausea, which is the Phenergan. But the side effect is that also makes them sleep, and which makes them more comfortable. So sometimes we give medications because we want that adverse effect. And then sometimes a patient can have a reaction to a medication that is very unexpected. An example is one time I gave Zofran to a patient. So Zofran is for nausea. I gave it IV. Patient had come in with dehydration due to nausea and vomiting. I gave the patient the Zofran. Zofran should make you stop vomiting, but also it shouldn't cause someone to be drowsy. It's not necessarily supposed to cause drowsiness. Well, I gave it to the patient, and about 10 minutes after I administered it, the patient was just, difficult to rouse. You could wake them up, but they would go right back to sleep. That's not a normal expected reaction from that medication. So that was an adverse reaction that was specific kind of to that patient. Most patients don't have that issue. So we did talk about therapeutic index. Please know the difference between the lethal dose, the toxic dose, and the median effect dose. The median effect dose is what we're looking for. The median effect dose means that 50% or more of the population got the desired result. Well, they had a headache, they took Tylenol, their headache went away. The median toxic dose is 50% of animals that were tested had toxic effects. So that would be like, we have a limit that we give Tylenol. 4 grams of Tylenol is all anyone is supposed to have a day. And that's because that's all our liver can handle. After that, it could build up and have a toxic level and cause damage to the liver. And then the lethal dose means that 50% of the animals that were given a dose of that particular dose of medication, it actually caused death in the animal. And so things that potentially could cause that would be things such as when people do when people take chemo treatment, there's a very narrow window with certain medications that are given during chemotherapy that can be toxic or lethal. So we have to be very careful about that. Also, if someone has a disease such as a kidney disease, a heart disease, a liver disease, the therapeutic index may change for them for the effective, the toxic, and the lethal dose. So conditions can also affect that. So just be sure that you are aware of that. The relationship between the medium effective dose and the lethal dose, sometimes there's just a little bit, and sometimes there's a huge difference. So like with lithium has a very narrow window between the therapeutic dose and the toxic dose. And then fentanyl, which is in the news a lot these days because it's being widely abused. The therapeutic lethal dose on that, it also has a moderate range. So We just have to be aware that there can be varying differences in what is healthy for a patient and what can be lethal with some medicines. Okay, so let's move right along to immune-mediated response. So some people are genetically predisposed to have certain sensitivities to allergens. So we always ask, in the clinical field, we will ask if someone's parents are allergic to things. We will ask if, especially with children, we'll ask if the parents are allergic to penicillin, and we may or may not give them penicillin, or we watch them a little more closely if the family has an anaphylactic reaction to something. The same thing happens with things such as gluten issues, with heavy metal issues, same kind of thing, that they can have a sensitivity that is genetically enhanced or genetically more likely for them to have that. Medication sensitivity, and this is something else I want you to remember, because I've had people kind of balk about this, but you can take a medication today. I can take Tylenol today and I not have any issue with it whatsoever. Well, actually, I'll use an example of myself. Okay, so an example of myself, for me, someone who has taken a medication and a sensitivity occurred the next time I took it. When I was working in the hospital, I worked in a little hospital a long, long time ago, and after 5 o'clock, the pharmacist was left for the day. And so as the house supervisor, I had to pull meds out of the pharmacy and mix any medication that an LVN was going to administer, because an LVN could not mix an antibiotic to give to a patient. She could go hang it, but she couldn't mix it. So I would have to go and mix medication. Well, I had taken tetracycline as a kid for bad acne. And I had taken it every day for probably 2 years. I took it every day. I hadn't taken it for many years. And then I went to go mix a dose of doxycycline, which is in the same family. And as I'm mixing it under a hood that has that's actually pulling the air up, and I had gloves on, I noticed that whenever I injected the fluid into the powder, I didn't feel, I started to my arm started to look funny, kind of had a rash. Mixed it, took it down to the nurse, and by the time I got to the nurse's station, which was about 100 yards away from the pharmacy, I was short of breath. My chest was tight. My throat was tight. A long story even longer, I ended up in the emergency room and actually in the hospital overnight because I had such a severe reaction to that doxycycline, which I had taken it in a pill form for 2 years of my life. So you can actually have an adverse reaction to a medication from taking it from one time to the next. So always remember that just because someone doesn't have a reaction the first time they take it doesn't mean they won't the next. Any patient who says they have a serious reaction to something, which means shortness of breath, tightness in the chest, itching, GI symptoms, nausea and vomiting with it, we want to avoid administering that medication if it's at all possible. Also remember that there are medications that patients take that they build a tolerance to. Narcotics is a big one. Anxiety medication, certain anxiety medications, people build a tolerance to those. And so know that if someone was taking a certain dose of it, say they're taking, say that they are taking hydrocodone 5 milligrams 3 times a day, and they've been taking that for 2 years. It may not be helping their pain anymore because their body's built a tolerance to it. Now, if they stop taking it all of a sudden, they potentially could go through withdrawal. But over time, they actually have to take more of a medication to get that same effect. So just know that certain medications build a tolerance. A lot of those medications that the body builds a tolerance to are a scheduled drug. We think back to one of the earlier slides when we talked about scheduled drugs, those Schedule 1 through 5 drugs. A lot of those drugs are the ones that are Schedule 3, 1 or 3, 2 and 3, Schedule 2 and 3 drugs are the ones that they definitely build a tolerance to and need more of over time. Sometimes there are cross tolerances that are done that are related to different classes of drugs. So another thing that we build tolerance to is if we don't take our antibiotics appropriately. So if I have a urinary tract infection and I need to take Bactrim for my urinary tract infection, and I only take 3 of the 7 days because I feel better, the next time, not only may my urinary tract infection not react to Bactrim, but it might not react to any macrolide. So macrolide is the classification of drugs. So there may be 4 or 5 drugs that won't help that. So we want to remember that happens. And tachyphylaxis is repeated. Remember this term. Tachyphylaxis is repeated doses within a short period of time that cause a rapid intolerance. We think about that with cancer patients. So cancer patients, especially people with later stages of cancer that are experience intense pain, especially once it metastasizes to the bone, you may increase their dose of pain medication as a medical professional. You may have to increase their dose every 3 or 4 days because their body builds a tolerance to it so fast because we're giving them a repeated dose, because they may be on a fentanyl patch, plus they may be taking something by mouth, or maybe they're on what's called a continuous infusion through a PICC line or through a Mediport that's put under the skin. So just know that those are possibilities and what tachyphylaxis is. Medicine abuse and dependence. So when we think about that, we were going back to those medications that are misused and that are on the schedule, usually a scheduled drug. And it's not just patients that get addicted to drugs and misuse or abuse drugs. It's not just patients. Medical professionals do as well. Nurses and doctors and all kinds of healthcare workers lose their license all the time because of misuse or abuse of medications. We see it most often in stimulants like ADHD medications, cocaine, methamphetamine, Ritalin, Adderall. Those are all medications that can be definitely misused or abused. And a misuse of things like Adderall and Ritalin would be someone who is not ADHD or ADD diagnosed, taking it because it keeps them awake, or taking it. I know that Adderall is a drug that's misused a lot in college setting, so students can keep up with their workload. Depressants would be things like alcohol, pain medications, any kind of narcotic. Those would be depressions. And repeated exposure can cause habitual use, can be considered habitual use. Prolonged use of it can make someone dependent, which means if they were to stop taking it, they become addicted and they would go through withdrawal. Medication interference, other medication interactions. So that would be a medication that interacts with another medication, and it makes it something that is a non-desirable outcome. So a medication that might interact with a medication. Example. So I've talked about vancomycin already. So pretty much you can't take vancomycin with anything. And an example of that would be vancomycin is given IV. It's given over a really long period of time, 1.5 to 2.5 hours, depending on the dose. But while that's running in, you can't give anything with it because it will cause the medication not to work as well. Sometimes we give medications together because we want them to work, like Demerol and Phenergan, but sometimes we give things together and it causes a negative outcome. And if you are, as a medical assistant, you put in a drug into the electronic health record and you run it, and there'll be a little portion of it that runs to the compatibility of drugs. And if something comes up contraindicated, or it gives you a level 1 or 2 interaction, you need to let the doctors know, because what it can do is it can increase or decrease the way that medication, how effective it is. Like, you don't want a patient, unless they're being closely monitored, to take aspirin and Coumadin together, because aspirin is a blood thinner, Coumadin is a blood thinner, and so it may make them have excessive bleeding, which can cause a stroke, which can cause a person to have internal bleeding. So we have to be careful about those kind of things, and make sure that we are constantly helping the physician monitor what medications the patient's taking. Types of responses. So I am not going to go through this specific slide step by step by step. Just know that this is very important for you to know, and that you should really read through this, stop, pause, read through this slide, and give yourself about 5 good minutes to look at the examples, look at the description, and look at the actual type of interaction. Because those are things that, 1, you need to be aware of, 2, you'll be questioned about on your certification exam, and 3, you'll be quizzed about when we do the quiz over lecture 3 and 4. Okay, so now we're going to talk about pharmacokinetics. Pharmacokinetics is basically what the body does with the dose, like what happens after you take it. After it gets broken down and it actually gets into the body, then pharmacokinetics is what the body does with it. So it discusses, that's about how long it stays in the body and how much of the medication you get and how effective it is. And a lot of that has to do with the dose, the way, the amount that's given, the route it's given, and how the patient's doing overall. So if I give someone 500 milligrams of Cipro 1 time a day, even though the recommended dose is 2 times a day, because they have bad kidneys, I'm going to have to give it to them longer so we can get the right outcome. Also, if I give it to them by mouth instead of via IV, they're not going to get as much of the medication. So those are things that really impact the pharmacokinetics, or how the body uses the medication. Pharmacokinetics section of the medication profile, it's going to tell you onset, peak, and duration. So onset is how long it takes for the body to start using the medicine. So if I take Tylenol, a regular Tylenol capsule, it's going to take it about 30 minutes to get in my body, get in my system to start working. So that's the onset. When does it start working? The peak is the maximum amount of medication in my system for it to affect me the best. So about an hour and a half after that, it may reach its peak. And then the duration is the amount of time it takes the body from the time I take it in and it starts to work, from the onset until it doesn't work anymore and I'm getting rid of it. So know the difference between onset, peak, and duration. Those are really important because some medications have a really long duration, some have a very short. Some durations differ depending on what's going on with the patient. Absorption. So absorption is really important too to understand, and that depends a lot on how the body gets it. So if I give something IV, they get 100% of that medication. Bioavailability means how much of the medication, the percent of the medication that actually gets to the body to be used. So in the bloodstream, and it goes to the brain or to the liver, or it goes after it passes through the liver, or it goes to an infected site or whatever. The bioavailability is how much of the medication the body actually gets. So if I give someone an IV medicine, they get 100% of it because it goes straight into the bloodstream. But if I give it PO, it has to go through my mouth. It has to dissolve in my stomach. It has to get broken down some by the acids in my stomach. And then it has to go through what's called first pass through the liver before it determines how much of it the body actually gets. So out of 500 milligrams, I may only get 350 milligrams that's actually considered bioavailable once it goes through all of the process of being broken down and get to the bloodstream. If I give something rectally or like in a suppository, I'm going to get a higher amount than I would if it was taken in a pill, because that's going to dissolve in a very vascular area and go into the bloodstream. Same thing with like nitroglycerin. We give that sublingual under the tongue, or we as in a spray under the tongue, because if you look under your tongue, it's very vascular. It's in a wet membrane, so it dissolves quickly and goes right into the bloodstream. So we get a higher concentration. So how a medication absorbs and the rate of and what bioavailability, the amount of bioavailability is very important when we consider medications. Oral gastric tube, and NG tube medications. So sometimes we give patients medication not just orally, but sometimes we can't give them a medicine due to a tracheostomy, due to some kind of occlusion, due to some kind of surgery, and we have to give it through an NG tube. Also, sometimes we have to give medication through an NG tube or an OG tube because someone's overdosed. So an example of that would be charcoal. We have to give activated charcoal that way. Sometimes we lavage the stomach. We give normal saline through there. So we put fluid in the stomach and then we pull all the contents out. To be able to do that, to be able to put an NG or an OG tube in, or a person to take an oral medication, they have to be conscious. They have to be awake and alert and able to swallow. And I'm going to show you guys how to put an NG tube. I don't have an OG tube, but I do have some NG tubes, and I'm actually going to show you how to put one down our mannequin, not a human. They're very uncomfortable to go down. So you'll actually see what that looks like, to go an NG tube to go down. Endotracheal, that's given medication through a tube that's been like someone who's on a ventilator, that ET tube. The endotracheal tube is a tube that goes from the mouth down into the bronchus. And so sometimes we have to give patients medications that way, because it's the only way we can give it to them. So say we're going to give someone a bronchodilator, we're going to give them a breathing treatment. We actually have to give them more of that medication because of how that works. But just know that we can give medications down an endotracheal or an ET tube, especially respiratory meds. Intranasal. So that's anything we give intranasal, which is like a nasal spray. Like sometimes when your nose gets really stopped up, we may give Afrin, and that squirts up your nose. Some people take Nasacort, or they take what's another one? Anyway, things like Nasacort or Afrin, they may give it, and it'll open up the head real quickly, and that's because it goes right into the bloodstream through their nose is very vascular. It absorbs real rapidly. And if you have ever had a nosebleed, or you've ever been hit in the nose, you know the nose will bleed a whole lot because it's very vascular. Intravenous, once again, that's a very quick onset. We give that medication IV and through an angiocath, and it's 100% bioavailable because it goes right into the bloodstream. Now, there are some limitations related to IV meds. Some medications can't be given IV. Some medications, an example is potassium, we have to give it very, very slowly, and we have to give it over a long period. Normally, we give IV potassium over 4 hours. We mix about 20 milliequivalents with 500 milliliters of fluid, and we give that over 4 hours. Because, one, it burns really bad, burns the patient's vein really bad. But two, we have to monitor the patient very closely because it can change their heart rhythm. So there are limitations, or there are serious considerations when giving some things IV. Zithromax is another medication we give over about 2.5 hours, and it also tends to burn the vein. Phenergan. I told you guys sometimes we give medications that the FDA does not, in ways the FDA hasn't necessarily approved it. Phenergan is a medication that we give sometimes IV. It's not necessarily FDA approved, but we give it because that we need it to work rapidly. Well, that Phenergan burns really bad too, so we have to give it very slowly, and we have to mix that with water, with saline or sterile water, so that when we administer it, it doesn't burn as bad. So we have to be very careful. Also with Phenergan, if we give it straight, or even if we give it slow push IV and it leaks out into the tissue, so it doesn't go into the vein, it actually goes into the tissue, it can cause the tissue to break down. Vancomycin can break down tissue. Any kind of mycin can break down tissue if it gets, if the IV were to get dislodged and it were to leak into the tissue. Interosseous. So this is something I have not given a ton of interosseous medications. An interosseous, I'm going to let you guys watch a short video here in a second of an interosseous, of how an interosseous IV is given. They're generally given in the proximal tib fib area. That's where I've done them the most often. Done it with something called a Jamshedi. It's a specific kind of IV that's given, but there are your sites: the manubrium, which is in the sternum, the proximal humerus, the proximal tibia, the femur, and the distal tibia, or near the medial malleolus. Those are places, and those are the veins that they go with. I have given them in the popliteal vein, and I've given them in the greater saphenous vein. Greater saphenous vein the most often, because I've had to do interosseous IVs on, or interosseous medication administration for pediatric patients and people who are who are in shock or who are having serious issues. Now with interosseous, the needle is inserted into the bone. So it's either done with a very particular kind of air, it has a spring-loaded needle, or it's given, there's a little drill that it can be given with. You don't give it with somebody who's had a fracture in one of those bones. We only do these in really, really serious conditions, and we only leave them in place for 24 hours. Hopefully within that 24-hour period, we have gotten that patient to a place where we can put either a central line or a regular IV in. Anyone who has an interosseous IV site is in very, very serious condition. So I'm going to pause right there for a second. Give me a second. And I want to show you guys what an interosseous IV actually is. So I'm going to pull up a YouTube video for y'all to watch. Well, if I could type, guys, that would be great. Let me try one more time. Let's see if I can type. Interosseous. We're gonna watch an adult and a kiddo have it done, because this is a live insert. Well, let's not do a live insertion, because that's probably, well, we can watch this live insertion. So I'm going to let you watch this live insertion. I know the music is a little entertaining, but so this particular paramedic is actually having interosseous done while they're awake. A little. You actually watch them. They're doing it more. You see it's attached to the gun. Yeah. Go back a little bit so you can So you're feeling the landmarks. Okay. So see, she's down the head of the uterus.
No pushing.
These are painful. You're going to insert that needle into the skin until it feels bone. Okay. And the drill actually drills it all the way in the bone. Just all perfect. And now they pull the needle out. They're starting that IV. So that's an osseous IV on an adult. Now, let's look at an IO on a child. Hopefully this is one. We are not going to watch a real baby because it just, well, there you go. There's a kiddo. And once again, I'm going to...
Let's look at a natural intraosseous infusion on a living patient. The site is cleansed as for an IV with betadine and/or isopropyl alcohol if possible. In an emergency, this step shouldn't be belabored if those substances are not available immediately. The site is located by palpating two-finger breadths below the knee on the medial aspect of the proximal tibia. The needle is grasped with the butt end in the palm of the hand and the fingertips at the tip of the needle, resulting in a low center of gravity. Moderate pressure is used to obtain entry of the point through the skin and subcutaneous tissues. And a smooth, controlled to and fro twisting motion with moderate pressure is used to advance the needle tip through the periosteum and the cortex of the tibia. It pays to be patient and to continue use of only moderate pressure so as to avoid the complication of using too much force and carrying the momentum through the cortex and the bone marrow and through the opposite cortex, as we visited just before.
Okay, so as you can see, they're going through the bone. What he was talking about going through the cortex, both sides of the cortex, that means going through the child's bone. So you want, and through the marrow. So you want to actually get it in the right place. Now, not that you guys would be doing that, but I want you to understand what they mean when they say intraosseous. In interosseous administration, you can basically give almost any medication that way. Intermuscular, that's given a shot. You guys practice that. And you get about 75 to 100%, usually 75%, 80% of the bioavailability. You have to just make sure that you're using the right needle, you're using the right, you're getting it in the right muscle. Remember, we talked about how in the deltoid, you only give a half of a milliliter and no more. And then you can give no more than 3 milliliters in any other IV site. In the vastus lateralis or in the gluteus medius, we don't give more than 3 milliliters. So just remember that we use the right technique, the right medication, and that way they get when they receive that, they receive it. They get it. They get the maximum amount. Subcutaneous, that means we give it into the fleshy or the fatty part of the body. We do that a lot. We do a lot of sub-Q injections in the clinic by either teaching or administering insulin. It's one that we do most often. Sometimes doctors, if you're given an allergy shot for someone who is getting graduated allergy treatment, sometimes you'll give that sub-Q, depending on the physician. Some do IM, some do sub-Q. And so you give that medication sub-Q because it absorbs over a slower period of time. It helps prevent reaction. So for a diabetic patient, we want to give them that rapid insulin, and we want it to wait about 30 or 45 minutes before it starts to act, so that they have time to eat. The longer acting insulin, we still give that sub-Q, but we want it to have the right action or onset time. So there's slower absorption when it's something given subcutaneously. And let me open this back up, because for some reason I tend to do this to you guys all the time. And on regular PowerPoint, for some reason mine will not let me just go where I was. Let me go back here. We're way past that. We are doing really well on this. And moving along. Okay, now we can talk about dermal and transdermal. So those are generally a patch. They can alter alter a patient's clinical perception of how things interfere with other medications. Sometimes people think that if they take a blood pressure patch, there's something called a catapress patch. They can take that, leave it on for 3 days, and they don't have any kind of it helps them have less fear of interaction if they have to take another blood pressure medicine. Sometimes there's a Exelon patch, and that is a patch for people who have Alzheimer's, because lots of times Alzheimer's patients get paranoid about medication, and they can actually take that as a patch. We have hormone patches, birth control patches. Fentanyl is a pain medication patch. That way the medication is delivered continuously for a certain amount of time, and it absorbs directly through the skin. Sublingual is when medication's given under the tongue. Most often, sublingual medication that we give is nitroglycerin. There are other patients, but we put it under the patient's tongue. The bioavailability is a little lower, and so we give a maximum dose. So like sublingual nitroglycerin is 0.4 milligrams, and they need to be awake and alert for us to be able to give that so that they don't choke. So when you think about giving a medication orally, in any way orally, they got to be awake and alert to give it. A shot, I can give somebody who's not awake a shot. I can start an IV on an unconscious patient and give them medication IV or IM or sub-Q, but I cannot give them anything in their mouth if they are not awake and alert. Inhaled, same thing. I can give inhaled medication. If they're breathing, I can give a nebulizer treatment or oxygen or certain antidotes. I can give those with a mask. I can just put that over their face, and as long as they're breathing, they can get it. If it's an inhaler, like a hand inhaler, like a treatment for asthma, they've got to be awake, because they've got to be able to hold it in the right way, use a meter dose, maybe use an aero chamber or something along with it. So we want to make sure that we use medications the right way. If it's inhaled, based on just they need to be breathing, like through oxygen, through a nasal cannula, which goes in the nose, or a nebulizer with a mask that goes over, then we don't necessarily need them to be awake. But for certain other respiratory meds, we do need them to be awake to be able to take it, because it's still going to go in orally. It's going to go in through the mouth. Rectal medication, sometimes that is the preferred route, especially if someone has nausea and vomiting, or they and can't hold things down. Usually not subjected to first pass. That means it doesn't go into go through the liver, doesn't go through the stomach into the liver, and you get about 90% bioavailability. Suppositories are coming for things like Tylenol, Phenergan, things for yeast infection, things for hemorrhoids. Those are all things that come in a suppository type form that we can give. Yeast infections are given suppositories for yeast infections are given vaginally, but the rest of them are actually given rectally. Ophthalmic would be eye drops. So sometimes we give lots of different kinds of eye drops in the emergency room. We do that a lot with welders and farm workers who will get metal in their eye. So we have to give them one eye drop that will numb the eye, another one that will slow down movement, another one that will help us be able to see that metal better. So there's multiple things we have to do. Other ways we can administer medication, a person on dialysis, if they need an IV antibiotic, sometimes we give them their medication through the dialysis machine as well. So we have to be sure that we know as a paramedic that we know if someone's on dialysis, whether or not they discuss that with the physician. Do they need to get that medication while they're at dialysis? Okay, distribution of medication. We're going to stop here for today. You've had a busy day. We will pick up here tomorrow. We probably will very closely finish this slide presentation. There'll probably be 5 to 6 parts to this. So we will have a quiz over today in part 3 and 4. Today is Monday for you guys, Tuesday. So Wednesday we will have a quiz over part 3 and 4. And then we'll have part 5 and 6. And we will probably have a quiz over that a day or by the end of the week. So we'll finish pharmacology up this week. And you guys remember that you're going to get your practice questions on Friday that we'll look at and kind of work through for next week. So you guys have a great day, and I will see you soon. Thanks, everybody.